An auditory brainstem implant is a surgically implanted central neural auditory prosthesis. It is a treatment for profound sensorineural hearing loss in children and adults who are not cochlear implant candidates due to a lack of anatomically intact cochlear nerves or implantable cochleae. The device consists of a multi-electrode surface array which is placed within the lateral recess of the fourth ventricle along the brainstem and directly stimulates the cochlear nucleus, thereby bypassing the peripheral auditory system. The ABI device has an external and internal components. The external components include the microphone, battery, speech processor, external magnet, and transmitter antenna. The internal components comprise the internal magnet, antenna, receiver stimulator, and an electrode array. So how does ABI work? When sound is first detected by the microphone, it is converted into an electrical signal. This signal sends to an external sound processor where it is transformed into an electronic code. This code is transmitted via radio frequency through the skin by a transmitting coil that is held externally over the receiver stimulator by a magnet. Subsequently, this code is translated by the receiver stimulator into rapid electrical impulses distributed into individual wires which travel along the array to the electrode contacts which are housed within a soft silicone paddle that is placed along the surface of the brainstem, allowing direct stimulation of the cochlear nucleus. Indications for ABI can broadly be classified into two categories: the neurofibromatosis 2 patients and non-tumor patients. The current criteria in the United States for ABI in NF2 patients are 12 years or older with poor hearing bilaterally and large vestibular schwannomas that do not allow preservation of the cochlear nerve. As for non-tumor patients, ABI can be considered on those with deafness secondary to bilateral temporal bone fractures in which the cochlear nerve has been avulsed or resulted in labyrinthine ossification. Patients who suffered from meningitis causing complete ossification of the cochlea, and patients with severe congenital inner ear malformation such as complete labyrinthine aplasia, cochlear aplasia or cochlear nerve aplasia. Once a patient has met criteria for undergoing ABI surgery, thorough counseling with regard to expectations after implantation is critical. Patients should understand that an ABI does not provide normal sound quality and achieving open-set speech recognition is not achieved in most patients. Sound awareness may be a reasonable goal. Candidates should also understand the necessity of following through with post-implant speech, auditory rehabilitation to gain the maximum benefit from their implant. The evaluation for an ABI should be performed via a multidisciplinary team involving neurotology, neurosurgery, audiology, speech therapy, and neuropsychology. An ABI candidacy evaluation should first ensure that a cochlear implant is not a feasible option, due to the superior audiometric outcomes compared with auditory brain implant. Radiographic imaging such as magnetic resonance imaging and computed tomography is used to evaluate the patency of the cochlea, the presence or absence of the cochlear nerve, size of the cochlear nerves, aperture between the internal auditory canal and modulus. Radiographic evidence of an absent cochlea is a straightforward indication for ABI. However, radiographic evidence of cochlear nerve aplasia is less straightforward, since resolution can limit the identification of very thin cochlear nerves or those running with the facial nerve. Hence in these patients, functional tests of the auditory pathway such as conventional audiometry or promontory stimulation testing remain the gold standard for determining the presence of a cochlear nerve. Patients with gross sound perception or sound perception after promontory stimulation should first undergo cochlear implantation. Thank you for listening and please subscribe for more. See you next time.